It has been an exciting, challenging, informational 55 weeks that we have been addressing the coronavirus, which is a national pandemic, an international, worldwide pandemic, excuse me. And one of the things we wanted to do in setting up this webinar was provide an opportunity for us here in Flint, Genesee County to understand the resources and services that were available to us so that we can fully understand how to address this global pandemic in our local community. And today we're excited to bring to you a wonderful panel that will help us get some insights on some of the questions you as community members have asked. I want to, again, as we've done every week, appreciate the 45 plus partners that have joined us every week since March 20th of 2020 to talk about these concerns and issues that are raised by our community members. Today, we want to appreciate everybody that has joined us today versus yesterday, our normal webinar is held on Fridays, but in observance of Good Friday, we chose to do this special live stream YouTube today for you. So I trust that you, those of you especially that are social workers, complete that survey so that you can get those continuing education units that are being made available to you. It's really been an interesting time for us. We've talked about the coronavirus, and there's so many things that we're learning. And I talked to many of our panelists over the last few weeks that we're continuing to learn about what this is all about. So it's relevant to the Healthy Flint Research Coordinating Center that was stood up in 2016 to help us address research that was coming into our community regarding the water crisis and related issues. So now here we are, COVID-19. 2020, a whole year has passed, and there are questions about vaccine safety for pregnant women and pregnant and lactating women. There are questions about vaccine safety for children, vaccine availability for Flint and Genesee County, and of course, understanding the whole notion of informed consent and how that makes a difference for us. Our panelists today are here to respond to some of these questions for you. We're excited to have Dr. Pam Hackert with us today, who is the Chief Medical Officer and Health Officer for the Genesee County Health Department. We also have with us Dr. Omari Young, who is a physician at Hurley Medical Center. We have with us Dr. Lawrence Reynolds, who is a retired pediatrician and wears a number of hats in our community, and is also serving as the Chief Health Advisor to the mayor. And we have with us Dr. Jennifer Edwards Johnson, who is working at MSU and is working at McLaren Hospital. So this panel is going to just give you some insights, particularly on their area of expertise. Let's start with you, Dr. Hackert. Just tell us what's happening in Genesee County Health Department.
Lots of great things are happening here. We are getting a large increase in vaccine availability right now for the last 2 weeks. Yesterday and today, we've had a really strong National Guard presence at our clinics, which makes it go very smoothly. And we're very excited about all these things going on. I would tell you one of the concerns, or one of the things that we've been working at, is a bottleneck with regard to getting people registered to get vaccinated. So people who would like to get a vaccine in this next week or two, please do the registration form online, because we have the vaccines now. We want to get them in people's arms.
Thank you, Dr. Hackert. Dr. Reynolds, you know, there are a lot of questions about the children and vaccines. What say ye about what's happening in that world?
Yes, there are a lot of questions about the children and vaccine, and those questions are being answered in clinical trials. Pfizer and Moderna will be wrapping up their clinical trials, but they won't be ready until June. So this does take some time. Each one is using a smaller group than what we used for the what was used for the adult trials. 2,000 volunteers aged 12 through 15 for Pfizer, and Moderna is using 3,000 volunteers in the same age group. So we will see how that goes. And later on, AstraZeneca, who makes a vaccine with Oxford University, will also be testing in Great Britain. So things are developing. And what I say this week maybe a different headline next week. And sometimes those headlines are premature and don't really disclose the information that we need. But testing is ongoing under, and the testing must be presented and approved by the FDA in phase 3 clinical trials in order to get approval.
So we talk about the FDA, Dr. Reynolds, you talked about the Federal Drug Administration.
Yes,
So
yes,
at
the
the federal level, Food and Drug
federal,
Administration, excuse
yes,
me.
yes. So no steps are being skipped, but there is an advantage because the vaccine has been released in adults and we have some experience now. We can move on to children. Now, the next phase will be younger children, and that will be much later this year.
Thank you, Dr. Reynolds. And so, of course, we're talking about children, but that leads us to, so what about these moms, Dr. Omar Young? What about these moms that they're currently pregnant and some of them who are breastfeeding? How does this vaccine affect them?
Again, this is Dr. Young. I'm an obstetrician and gynecologist at Hurley Medical Center. I get this question all the time from close friends, family members, patients in the community. And it's an important topic because pregnancy and women who are contemplating pregnancy, they want to have answers because this is a sensitive subject when you're thinking about growing a family, not only during a pandemic, but also when you get an emergency use authorization of a vaccine when the initial trials didn't include pregnant women. So there's going to be a lot of apprehension to the vaccine, particularly in marginalized communities where we are usually excluded from clinical trials. But the American College of Obstetricians and Gynecologists, which is ACOG, which is the governing body for my specialty, we made a clear stance that the vaccine should not be withheld from pregnant women. Although the initial studies did not include pregnant women, we know that the pharmacology of the vaccine, which is not a live virus and it's an mRNA virus, it doesn't attack cells that contribute to fertility, which are the ovaries. So we know that just from pharmacology that it shouldn't affect the fertility. And another supporting body, which is the American Society of Reproductive Medicine, again put out another statement reiterating that a lot of the claims that we see in social media and throughout the news that the virus associated with the vaccine can lead to infertility, that is false, that is incorrect. So I recommend to my family members of reproductive age, friends of reproductive age, and my patients that I see at Hurley Medical Center to get the vaccine when if they're contemplating pregnancy, and also if they are currently pregnant. And obviously everybody likes to see data. So we know that vSafe, which is the CDC's health check-in tracking system that we use on a smartphone. So they reported data specific to pregnancy. So as of February 16th, 2021, there were 30,000 self-reported pregnancies who received the vaccine, whether it was 16,000 pregnant women who received the Pfizer vaccine and 14,000 who received the Moderna vaccine. And then furthermore, they're specifically making a vSafe pregnancy registry so they can follow specific pregnancy outcomes of women who have received the vaccine. And currently, as of February 19th, 2021, there are 1,815 women who are in the pregnancy registry for vSafe after receiving the vaccine. And the particular outcomes they're looking at are miscarriage and stillbirth, pregnancy complications, maternal intensive care unit admission, adverse birth outcomes, neonatal death, infant hospitalizations, and birth defects. And of the women that we have seen so far who are registered as of February 19, 2021, the most common outcome was miscarriage, and that was around 15%. And this is obviously a very small number, and obviously 15 is raised eyebrows, but when you look at the overall rates, what we call background rates of miscarriage, is actually 26%. So there's no data that supports that women who receive the vaccine compared to women of the same characteristics who didn't receive the vaccine are higher risk of adverse pregnancy outcomes or birth outcomes. So as we get more data, we'll have more supporting information. But I think that's what can be reassuring, that we actually are tracking specifically pregnant women through the CDC, through the VSafe pregnancy registry. So as we continue to get more women who are pregnant vaccinated, we'll have more data to support that those outcomes that many moms are rightfully so worried about. We can reassure them that the vaccine will not lead to increased morbidity or mortality. And then along with lactation, the Academy of Breastfeeding Medicine, they made a statement also supporting that lactating women should also receive the vaccine. Particularly, we know that, again, the pharmacology of the vaccine, vaccines should not be expressed into breast milk. And then actually the opposite, we know that it could be beneficial because we know that the antibodies that are produced by the mom after getting a vaccine can be found in the breast milk. And that's been supported in recent statements and case reports of newly vaccinated moms with their reported COVID antibodies in breast milk. So it's actually potentially beneficial to your newborn child.
So Dr. Young, you added some really big words for me. So, so I just need you to tease out a couple things.
Okay, no problem.
When you're talking about pharmacology, you're actually talking about the study of the medicine or the study of the
how
vaccine
it works,
and how it works.
Exactly.
So you're looking closely at that to really be sure about the impacts of it. Mm-hmm. So you also mentioned then, you said most of the times people like us are not included in these clinical trials. And when you mean like us, you mean particularly
minorities, so particularly African Americans. And then also we know, generally speaking, women are excluded compared to men in clinical trials, and definitely pregnant women for multitudes of reasons. So as we get more information over time, we can gain more confidence in the community, especially marginalized communities, particularly African American women.
So we're thankful that you're part of this conversation. So is there in these trials, and this is a question that's being asked, in these trials, are there more, is there an effort to get more African American women in these trials?
Yes, there is. Right now, the data, I don't know, I haven't seen any data that teases out the racial breakdown, but they are, I'm sure down the road, they'll look at the racial breakdown of the women who are included in this VSafe pregnancy registry. Oh, Dr. Edwards-Johnson.
Yeah.
So go ahead. Sorry.
You're going to respond to that question. Go right ahead, Doctor.
Yeah, I was just going to say that with Pfizer and Moderna original trials, we know that the racial breakdown and the demographic breakdown tried really and came really close to sort of mirroring the populations. And I expect Pfizer just enrolled a study to look at pregnant women. And I expect that they'll try to mirror that as well, right? Make sure that demographically they're getting a lot of push, rightfully so, from community members like yourselves, from lots of people saying we need to make sure that the demographics of these vaccine trials are very similar to the demographics of the population. So I would definitely kind of co-sign what Dr. Omar Young was suggesting, that we're hoping that we'll get data that's reflective of the population.
So now, Dr. Johnson, here you are, Dr. Jennifer Edwards-Johnson. You are what I'm calling our generalist. You are a family doctor. You want to talk about all of this. So when you talk about generally mirroring the community, you're talking about looking across the intergenerational issues. And so it's not just limited. So from your generalist perspective, how are we really doing with what's happening with the vaccines and encouraging vaccinations?
Wow, that is a great question. I think, we have struggled with our vaccine rollout across the board, and there's lots of reasons for that. We've talked a lot about vaccine hesitancy in our community, and Dr. Deb has talked a lot about, let's not talk so much or focus on vaccine hesitancy, but let's talk about focusing on getting the vaccine to the community and barriers that exist to getting vaccines to community, right? And Dr. Young kind of alluded to some of those barriers. Not being included in vaccine participation or vaccine trials, communities not being kind of first in line to receive a lot of vaccine, and even some of the age groups and the sort of stages of vaccine rollout have some level of contributing to barriers to getting vaccines into our community. The other piece of it is kind of what we talked about with some worries about safety in pregnant and lactating women, right? Some worries about safety in children. Pfizer, the data that we have from Pfizer, right? Pfizer's original trial data enrolled children as young as 16. So we have some data that gives us some information about that, and we're able to vaccinate children as young as 16 with the Pfizer vaccine, and we're getting good data from that. As Dr. Reynolds suggested, Pfizer recently had some 12 to 15-year-old data as well, right? So we're seeing an early data from Pfizer, we're seeing 100% efficacy in that data set, right? So that's really great. So when we talk about across the board, where we have the most kind of data is that sort of young adolescent age to that sort of older age group. One thing I'll say is in our pregnant, lactating women, in the populations that we get really concerned about, right? Those populations are at much bigger risk of COVID infection and the outcomes of potential COVID infection than any of the risks that we actually see with COVID vaccination. And so those are the things I think it's really important that Dr. Young kind of alluded to, this idea of we're tracking all of the potential vaccine outcomes that could be adverse or negative. We are looking at all of them. And what we know, even without the data that we have on people who have been vaccinated, what we know is that COVID-19 outcomes are severe and far worse. I really appreciated the comment Dr. Young made about, we see a rate of miscarriage with the vaccine of somewhere around 15%. But that is relative to our normal rate of miscarriages. So if we look at everyone, the rate of miscarriage, I think Dr. Young said in the general community is somewhere about 20%. So we don't see any higher level of miscarriage when we're talking about vaccinated pregnant women. And that's affirming. That makes us feel better, right? So that's all I got in terms of generalist stuff.
Yeah, so thank you. And we're going to come back to some questions too, based upon some of the things that you said, but all of you have talked about the data and how important data is. And we know that's captured in research, and we have some real concerns about research generally in the community, and particularly in our minority and racially ethnic diverse communities. There's a lot of concern about this. And so one of the things that came forward based upon some of this history is the notion of informed consent. And I want to go back to you, Dr. Hacker, and let's talk about the idea of informed consent, because when you talk about this V safe, and I think that's V as in vaccine safe tracking, and what's happening in our communities in terms of getting people vaccinated. Can you talk to us a little bit more about the informed consent process, and that this is something that's really important for all of us to understand?
Yes, it is indeed. And we try and do, when you're trying to treat 400,000 people at a time, it makes it hard to do some of the individual information that you would like to have. We have been exploring that, though, because it is important to be able to make sure that people have the information, have read the information, and understand the information. And so we are doing multi-pronged approaches with that. I was actually just looking up the one study that came out a couple of days ago about pregnancy, because they did show some benefit to mothers, but I also wanted to see if they had any racial diversity in there, and they do not. It said that it was 131 people who were mostly white, non-Hispanic, because they were all the healthcare workers of the one hospital that was participating. So that's very disappointing with that one. But when we have people sign up, we provide information both on the website, we provide links, we provide information when you're signing up, but that's really not enough at all. And so the things we also have been doing is people fill out their forms, and on their forms there's different discussions, but that again is not enough. And sometimes people are just giving information over the phone. So when we have people in line, what we have been doing is asking the questions, talking about that, asking people if they have questions, but then you are relying on the individual who that person is interacting with in line. And I'm trying to make it so that we have ways to guarantee that more discussion is needed with the people who may not be really vaccine hesitant so much because they're actually in line to get the vaccine, but they still have a question or two that they would like answered. And I have just actually been talking with our newest member of our health care team at that county, and she has recently come from Oakland County and has said, well, how are you guys doing it? So they are doing it. We were thinking of trying to do more of a radio broadcast where you tune in to get questions and then be able to flag that you want more questions answered. And or if it's a walk-in, we could do a video. But she said they're actually going through and putting an additional step in between check-in and when you are about to get your vaccine, where someone's going by each person and saying, let's talk about this. Did you have any additional questions? So I think that is something we will be seeing probably next week, starting at our clinics, because it is so critical to be able to meet people with both the understanding, the correct language, answering their specific questions, and giving them the information. One of the things that's nice with informed consent is some of the questions people have had all along are starting to be answered now that we have the 3 months of historical information and such a massive scope of it. We are seeing that about 55% of people do have some side effects to the vaccine after the first shot, and about 80% will have reactions by the end of the second vaccine. And interestingly enough, the Johnson & Johnson, which is the one and done vaccine, they have fewer side effects because it's the one, but it's actually comparable to that 55% that you see with the first dose of Moderna and Pfizer.
So if I understand what you're doing, Dr. Hackett, when people come all through this process, they're being given information so they clearly understand the process, and they're also having an opportunity to ask questions about what will be happening during the process. So we really want our community members to be fully informed. So I want to just kind of go over to you, Dr. Reynolds, when we talk about informed consent, because children can't make these decisions for themselves. They don't have the ability to have somebody read to them and talk about what's going on. So what's the process for parents as we're moving into this whole conversation about having younger people under the age of 18 participate in this process? How are they fully informed about what's going on? I think you're on mute, Dr. Reynolds.
It's hard to, thank you. It's hard to explain to a 3 or 4-year-old what's going on. But when we get around, I'd say 11, 12 on up, we do have to explain to children what we're doing as well as parents. And at this point, if you're under the age of 18, there's many things you cannot consent to, and you need an adult's permission. So we can talk about how a vaccine will prevent a virus or a disease from causing a serious infection. We probably will talk less about the ingredients in a vaccine. Those would be questions that would typically come from somebody 14 on up, and especially in the young adult age range. And I recommend to those folks, well, if you expect me to list all those ingredients and it's not on the consent, I would suggest before you come in, you go to the CDC website that lists COVID-19 vaccine ingredients, or the FDA website, and you can get that information. Many of them are common to what's already in the vaccines that we get. And then, as is mentioned before, there is a website where you can report reactions to vaccine. So there's the Vaccine Adverse Event Reporting System, which is also on the CDC website if you have a problem. And you can see some of the things that have come up. Now, I caution you, just because you read something in the newspaper or hear something on the news or hear something from your cousin Annie, that does not mean that those things are related. To take it to the level of absurdity, someone may say, well, I got vaccinated and I had a car accident. Well, those two things aren't related, even though they may have happened around the same time. So we have to be very careful and look through the data to be sure that there is actually a relationship between the event of vaccination and the event that happened to that individual.
Yes. So thank you, Dr. Reynolds. Basically, you're saying we have a responsibility also to do some research, look into this, and get those questions answered even prior to going to get a vaccine or talking to somebody about what should happen, which relates to some of what you were saying, Dr. Young, when you said we're still learning. There's still tests being done. There's still studies being done. We don't have all the answers yet. And so it's important for us to participate in these clinical trials. So what would you say to people who said, I'm interested, but what do I do?
I think the other thing too is to go a little bit more upstream, and that we're talking about the vaccine, but also every time a patient is making a decision on receiving care, it's a risk versus benefit. The benefits of doing nothing and the risk versus the benefits and risk of doing the intervention. And we know we have data that shows that pregnant women, particularly African-American women who have comorbidities, at a higher risk for morbidity and mortality if they have symptomatic COVID-19 disease. So increased risk of hospital admission, ICU admission, and need for other interventions as compared to non-pregnant women who have symptomatic COVID-19 disease. So knowing that particularly minority women who have comorbidities in pregnancy, although we know that the absolute risk of getting severe disease is low, if you do get it, that those outcomes can be very poor for these women. So letting them know that this could be the potential alternative, and then we have our intervention, the vaccine, that is relatively safe and that we're also getting more information on. I would want them to make it make an informed decision, exactly, giving them all the available information and let them make an informed decision. So I think letting them know that the alternative could be these potential worse outcomes during your pregnancy, I think that would give them more confidence also in receiving the vaccine during pregnancy.
So, Dr. Young, you're giving us some great talking points, some sound bites that could become some good education pieces. And so, Dr. EJ, and I see your hand, Dr. Reynolds, if you can say something generally, I mean, to the general population about how to think through making these decisions.
Absolutely. I agree largely with what Dr. Young stated. I think when we as providers are talking about informed consent, a lot of times we focus on the intervention, the thing that we're doing for a patient, right? But I think the other side of it is exactly what Dr. Young said. What is the other option? What is the potential outcome? And as a physician, it is incumbent upon us to explain all of those potential solutions, all of those potential options that you have, right? So when we talk about COVID, you have the option to wear your PPE, spatially distance, wash your hands really carefully, and be careful, right? You have the option to do all of that and get vaccinated. And then we talk about the risks of either situation. And as Dr. Young suggested, right, the risk is much higher that you will get COVID if you are not vaccinated, and the risks and severity of disease are often much higher. And so that's what we talk about across all of the population. So that's what I'm talking to my parents who have young children about. And right, and young children can't get the vaccine yet. So we're talking about that first option a lot more with young children, right? Spatially distance, wear your mask. And in my sort of adolescent population, you know, we're having that conversation. Hey, the vaccine might be available soon. Let's talk about what that means for you. In our older population, we're talking about the risk of comorbidities and how COVID is especially awful in people who have comorbidities and has a high rate of severity in people who have comorbidities. And we're talking about it with parents and grandparents who, you know, might have comorbidities, are in nursing homes, and so might have a higher risk of exposure, right? And we're talking about those risks and benefits as well. And I think the thing to highlight is those risks and benefits differ across all of those populations, but largely the risk of COVID disease is much worse than any risk that we've seen. And that's the informed consent piece. Sorry, go ahead.
Yeah. So Dr. Johnson, you talked about comorbidities. You mean more than one possible poor health condition?
Absolutely. So when we talk about comorbidities, we talk about someone who might have hypertension, who might have diabetes, who might have COPD or asthma, some other condition that you have, that you're taking medication for, that you're seeing a doctor regularly for, those are the things that make us at higher risk oftentimes for severe COVID illness.
Thank you, Dr. Edwards Johnson. And I know we've got some questions in the queue for you. I'm going to swing this to you, Dr. Hackett, in a moment. But I know this part of the discussion is just like so close to your heart, Dr. Reynolds, when you talk about what else can be done. And I know you've got something you want to add to this.
Oh, yes, if I may, two things. Number one, as a physician, I don't recommend something for other people if it's also appropriate, if it's appropriate for me. So I had my two Moderna vaccinations, and I've told other people in other audiences. I have a 92-year-old mother. She's a retired nurse, but as soon as it was available, she was on it. So in my whole family, which is kind of large, from 18 to 92, well, actually, my aunt's 96, whoever was available got the immunization. Uh, so, uh, and actually, the older folks had fewer side effects than I did. And I'm one of the older folks. And so it varies. But as our previous speakers have said, you have to look at the risks versus the benefits. And number two, those side effects usually clear up within 36 hours. You know, I had with my second Moderna fever, chills, uh, soreness on the arm, and that started about 15 to 18 hours after the immunization and cleared up in less than 24 hours. And I did have to take Tylenol. But after that, I'm fine. And the trade off is what? My risk of being severely ill, hospitalized, or dying from the coronavirus or the COVID-19 disease is significantly reduced.
So, Dr. Reynolds, can you just take a moment now? The Swiss cheese model is
Okay.
I think is really important right here because you really can help us see again what we can do in our own way as a collective community to try to reduce the spread of this virus.
And I wish I could say this was my idea, but I found it reading the newspaper. But it's so solid because right now we do talk about the vaccine, and that comes out of shared responsibility, but it is a fundamental, essential, necessary part of our layers of protection. So anything I say after this is not minimizing the importance of vaccine, but emphasizing how all the other layers work together to protect us, the ones we love in our community. So you've heard about physical distancing. If you're sick, stay home. And that's appropriate for this Holy Week season. Number two, if you should wear a mask whenever you go outside or if you have guests in your home. Number three, hand hygiene and cough etiquette. That means cover your cough, wash your hands. Next, avoid touching your face. And I wear glasses, so that helps me to not touch my face as much. But you would be surprised that during the course of an hour, how many times you or I may touch our face.
Yeah.
And if you're in a crowd, you have to consider things the dose. You don't know how many people in there are blowing out coronavirus. So you have to look at the duration. If you're in a poorly ventilated room, maybe you shouldn't stay in there so long. Okay, and also the duration. Well, the duration, the dose, and the density. If you're in a crowded place, if you walk into a place and people don't have their masks on, I advise people to change your plan. Turn around and walk out. And if you have your family with you, turn around and walk out. Those are the personal responsibilities. And then there's the shared responsibilities in our community, in our local government, and our state and federal government. We still need fast, sensitive testing and, and contact tracing. That helps us identify outbreaks. It also helps us now identify the emergence of variants, the changes in the virus. We need to be in well ventilated buildings. And ideally, if we can do something outdoors, do it outdoors. And if you can get a air filtration unit or you need information about that, See your heating and ventilation specialists for your large institutional buildings. And then we have government messaging, and finally we have that and financial support, because telling the the full message is most accurate. And then following quarantine and isolation, because what we have affects the people around us. And once again, vaccines. Now, if you'll notice between the dark yellow and the light yellow, there's a little mouse there eating the cheese. That mouse is misinformation, getting information from sources that have no credibility, or listening to your cousin Joey. So unless that person can show you a website or some information that comes from our health department, our CDC, our FDA, or a medical group, you should seriously fact check. And if you don't know, ask somebody. Thank you.
Thank you, Dr. Reynolds. That's just powerful information. And information is good as long as you can get it. So, one of the questions for you, Dr. Hacker, we know that we have non English speaking individuals in our community. And so, what is being done in terms of the health department and getting information to our non English speakers, particularly as it relates to the vaccines? Do we have individuals that are working at the health department who can help individuals whose English is not their first language?
Yes. So first of all, I have to tell Dr. Reynolds, woo, that was a wonderful summary. Oh my gosh. It's like, we need you to put that on a little thing. We'll put it on. No, really, that was an outstanding summary. And I just thought, well, yeah, I have nothing left to say. But in terms of Spanish speaking, yes, we do have that. Our pre-registration links are completely in Spanish and English right on that. And we also have people available. So if you fill out the pre-registration form, which you can also get done through different community links, if you don't have access to the internet, we do have Spanish speaking people who will return your calls if you have questions and leave them in Spanish. But on top of that, we have been working with Our Lady of Guadalupe, and we have been doing a registration or a vaccine site there for probably 7 weeks now. And they always have bilingual speakers available there.
So, Dr. Hacker, we also have other communities in our, other ethnic groups in our community that English is not their first language. Is there some efforts being made? For an instance, one of the participants says, are there efforts being made for translating into the Arabic language?
So we have tried to we don't have it in our actual survey online, but we do have information in different languages online. And yes, if someone does not speak English as a primary language, if they can have someone call or send an email either, or just communicate at all, we'll make sure to be able to do that. We do have access to that, but we don't have it set up. We're without a little bit of extra steps in that one.
So one of the things we appreciate, Dr. Hackett, is you've made these steps as, I want to say, somewhat of a newbie to our community. You came in, hit the ground running, got here in January, and already you've opened up some tremendous opportunities for us to get information, as well as have opportunities for testing and vaccination. So you're offering an opportunity for our listeners today, if you know that there's some specific needs or gaps in our community, to reach out to the health department. Their website is available. Send them a note. Dr. Hacker's been in a number of places to help make sure our community can get connected. So is there anything else in that arena, Dr. Hacker, that you'd like our community to know about and invite them in to support?
So we have been working very hard to make sure that we have vaccine sites available where they're needed, and kind of to know that it's going to be happening regularly. One of the things, though, is our vaccine supply is increasing just tremendously. This coming week, if you count our second doses as well as our first doses, we have over 20,000 vaccines available. 11,000 of those are the Johnson & Johnson. So to be able to start to come close to distributing that, we are working with partners who may make it a little easier. We are starting to work to distribute to private providers in the county. The requirement for that would be someone who can either gather a group of providers together who can say we will do between the 3 offices, do 100 vaccines a week, or if it's a larger group, we could do directly to that person or to that group. But we're also making vaccines available through Kroger, and that will be available at any of the Krogers in Genesee County that has a pharmacy. We are also then going to try and increase our hours at the different drive-through clinics, which is where we can really process a lot. So today at Bishop Airport, we have a total of about 1,400 people coming through, and that is about 200 to 300 more than we have done previously, but that's still within a 7-hour day, and so we're going to be extending that to a 10-hour day soon, which will increase it quite a bit. So we're really focusing on that. If people have individual needs, we have a lot of community groups or community faith-based groups that we'll connect with to say, I'm still not able to get to any of these clinics. I need help, and we are then this week starting with our county paramedics. It's going to be small because they are obviously being pulled in many directions with all of our vaccine sites, but it is starting this week where they will go and do homebound individuals. There's been a couple other agencies that we are working with to try and increase that number as well, because we have identified a couple thousand people who need actually to get the vaccines in their homes. So we have probably at least 3 different levels of each group that we have been able to identify that need this. We are working at 3 different ways of trying to address that, but sometimes little snafus are happening.
So, but we've come a long way. We went from not having vaccines at all, having limited vaccines, and now we have this larger opportunity. So we just want to continue to encourage individuals to ask the questions, like was said earlier by Dr. Young. It's important that we're able to make informed decisions. Dr. EJ.
I just wanted to take off my family physician hat and put on my community assistant dean hat and just put a plug in for our MSU-CHM Flint students and for Dr. Hacker for allowing our students to work with the health department to distribute vaccines. So our students, we have several students down at Bishop Airport right now distributing vaccines, putting vaccines in arms. Dr. Laura Caravala is our fearless leader who's been kind of leading that effort in collaboration with health departments to get vaccines in arms. So our students are really excited and engaged and really wanting to be a part of that that work, and they're doing a great job kind of getting out there and forming communities and distributing vaccines.
They are.
So thank you to Dr. Hacker.
They're invaluable, honestly, and it's not just like they're doing it to check a box either to say help with vaccine clinics. They are there every single time, same faces even. It's been really an amazing thing, and not just the physicians but also the nurses too.
So this is a question for any of our panelists. I get this question all the time, and it's so excited to know we have all of these boots on the ground now that's helping make a difference. But one of the questions people ask is, so what's the timing of all this? Dr. Reynolds, you mentioned quarantine isolation. We're mentioning testing. So this is a really broad question. So if I've had COVID, should I get the vaccine? How long should I wait to get the vaccine? Or am I okay? Am I fully immune forever?
I can take that if people would like. So yes,
everybody's got to answer.
you should get the vaccine if you've had COVID already. There's a lot of evidence that actually people who have had COVID don't go out and get it on purpose, but people who've had COVID earlier on and maybe wondering if they should get the vaccine, they are absolutely with one dose of the vaccine, it's showing up to 50 times someone who never had COVID. So it really just solidifies the immune response by getting at least one dose of one of the COVID vaccines right now. And the timing of such is that you want to make sure you wait at least 10 days from when you either tested positive or had symptoms onset. But really, probably about a 3-month period is the golden spot. You just don't, you can't come and get it while you're still infectious, but 3 months is when you really boost that and strengthen your immune system.
So I saw Dr. Reynolds and then I saw Dr. Young. You all are nodding. Dr. Reynolds, you have something you want to add? I think you're on mute, Dr. Reynolds. Profound,
I'm
profound
always
statement.
on mute. Yes, because antibody levels do wane after 3 months if you've been infected. So it's important to get that vaccine then. And in rare circumstances, you can get a reinfection. And we like to say it's predominantly a problem for people over 65, but it happens, it pops up in any age group. So uh, that's most important. Just because you had COVID doesn't mean you have sufficient immunity that will be long lasting, and so that's most important. And then the issue of herd immunity. There's no guarantee that if everybody got COVID, we'd have that herd immunity, that population protection against the virus. The vaccine is the most reliable way to do this.
Thank you. Dr. Young.
Yes, I agree with everything that was said by the other panelists. The CDC recommends that it's unlikely within 90 days after infection that you will get it reinfected. But like Dr. Reynolds said, that there are documented cases of reinfection within that 90-day window. And definitely, like with any vaccine, you shouldn't get the vaccine if you're currently symptomatic or sick. So you should wait until after you're symptomatic.
So thank you, doctors. And that leads us to the question. So I've got the vaccine. I've already had corona. Can I get it again? Dr. EJ, what'd you say?
I always say yes, right? There's always that possibility that you can get it again. That exists, it's out there, that possibility is there. What we do know is that your risk of getting severe disease or having to be hospitalized or dying is much less. It's much less than if you had not been vaccinated. So there is almost all of the vaccines, specifically Pfizer and Moderna, are somewhere over 90% effective, right? We're seeing numbers about over 90%, which means there's still, that little chance that you could encounter COVID and you could become sick. But that chance means, you're much more likely to have mild symptoms and you're much less likely to be hospitalized or die or have severe illness as a result.
And I think that goes back to what Dr. Reynolds alluded to earlier, is that we're now knowing that there are variants. So it's not, so we don't know that having the vaccine will protect you 100% from all the different variants yet. So as we get more data, we'll have a better understanding of the immunity. And I think one of the recent studies, it says we have at least a minimum 6 months of coverage. But again, as we get more information and learn more about the virus and the vaccine response, we'll have better information.
So you're back to that issue of data, which means there's some more studies, some more research. And so I think from the perspective, again, of the Healthy Flint research, it's here that Healthy Flint research. We want to do research that is helpful to the community in a way that's going to benefit the community. So it's important for us to have this understanding and be willing to participate and offer recommendations as much as possible. So this gets us back to the question of the testing. Why is it still important, even though we've got vaccinated, we've already been tested 2 or 3 times, for us to continue getting tested? Dr. Hacker?
So that's one of the discussions that's going on right now, like literally every day in the last 4 days, has been the health officers of the different counties sending group messages saying, I need vaccine breakthrough, because that is cases identified in people who've already been vaccinated. So we have one in Genesee County that we suspect is someone who has gotten vaccinated and may have now gotten COVID, but some of the smaller counties are seeing like 4 cases, and you wonder, well, what was happening on those situations? But it is something that can happen, and if you have signs and symptoms of COVID after you've been vaccinated, you do want to get tested so you know that is what it is. And if it's not COVID, you then need to find out what it is as well.
Thank you. Dr. Reynolds.
Oh, I agree 100%. If you have symptoms, get tested because you can have picked up the infection without symptoms before you get vaccinated 2 or 3 days later, and then it becomes manifest. So if you have symptoms, don't say, well, I got my vaccine, everything's good, I should have no problem. Get tested. And even after the 2 week period, when most people have adequate protection, if you have symptoms, get tested. So these things go together, and that goes back to those layers of protection.
Thank you. Dr. Young, Dr. Dr.
And then also, particularly when they refer to testing when you're symptomatic, is the PCR testing. But then also there's a role for the antibody testing, which can give us a general idea what's the overall community spread and exposure. Because like we said, not everybody who has COVID shows severe symptoms or symptoms at all. So when you're potentially think that you're infected and sick, it's the PCR testing or the rapid antigen testing. But then down the road, and I'm sure Dr. Hacker can speak on that, there will be some role in public health as far as the antibody testing for communities.
Thank you, Dr. EJ, and then we'll go back to you, Dr. Hacker.
I think the only addition I have is we talked a little bit about the potential for variants, and the only way we know about variants is if we're testing. So the only way that we have effective boosters, the only way that we can kind of surveil and look at what the population is doing relative to variants is to be adequately testing and rigorously testing. So I think that's important too.
Thank you. Dr. Hacker.
So yes, I agree completely with Dr. Young with that. One thing I do want to talk about with the variants though and quarantine, that has just changed now. They are suggesting that the full 14 days is again enforced more because we are having variants. We have over 1,300 variants identified, not different variants, mostly the B117, the one that arose in the UK, but we have different cases of it in Michigan now. And that is why we need to make sure that people are actually staying home with their full quarantine to prevent the spread of that. But the reason that that is so important, it's not just a transmission, but it's also because it takes about 7 to 10 days minimum to get the results. So you find out you're positive. You say, okay, I'm positive. But it takes 7 to 10 days to find out if that was actually a variant. Because the way the lab is run, they have to set up machines, they run a different way. And so you may find out after you're already done with your 10 days that you indeed had the variant, and then it's looking at the people you were in contact with. So if you maintain isolation very carefully, then you haven't spread the variant. But if you were a little bit more lax in either a quarantine or isolation, if you were actually diagnosed with it, then you have potentially spread the variant.
So it's important for us to get tested early. If you have symptoms, start your quarantine process. And if you find out you're positive, stay quarantined for that full 14 days. This is a way we're going to add to those layers of protection for our community. It's so amazing to me how quickly this hour goes. So I want to ask each of you to think for a moment as I ask Dr. Deborah Forholden to join us in this conversation to talk about the importance of mandating equity, because I'd like to give you all an opportunity to give us one last closing thought. Dr. Deborah, there's been a question. We've talked about the equity issue, how many people are affected, and what we need to do to change this dynamic. Dr. Deborah, can you give us an update on the mandate equity?
Okay, you didn't call me out from the background, Yvonne.
I did.
I'm here, and I think it's important because I always give the analogy, and I ain't gonna lie, I'm in the background producing today. I got my wonderful co-producer here, little Miss Olivia Holden, who herself was a COVID case. My 19-year-old U of M Flint freshman contracted COVID. I was really grateful because I didn't contract COVID. I've been vaccinated, had both doses. We honor protocols even in our house. My son did not contract COVID. We were able to, keep everybody safe. This notion of mandating equity, and it's really great that Olivia is here with me, because young people are really taking up the reins to help us reel in this pandemic. there's a movement afoot. Somebody said it to me. It was one of the chief advisors for President Biden. And they said equity is a weak muscle for our government. It's a weak muscle. It's a new muscle. It's one that we haven't had to use or exercise. Our country was basically founded with inequity baked in. And so now we're trying to figure out, the very first time I ever made a cake with Olivia, she insisted that it be a cake we made from scratch. So we went and got all the ingredients. And we were done, and there was flour all over the place and stuff everywhere. And she's standing at the oven looking in, waiting for the cake to bake. And as I was cleaning up everything, I noticed there was a box of Domino sugar still on the counter, and it was unopened. And I said, dang it. And she looked back, Mom, what's wrong? I said, baby, we forgot to put the sugar in the cake. And she was about 6 years old, and in her beautiful, I love this girl so much. She hates, I tell this story because it really does capture something. And she looked at me with her real big, beautiful, innocent eyes, and she said, well, Mom, can't we just sprinkle some on top? And everybody knows if you've got a fundamental missing ingredient, if you have baked the cake and you did not put the sugar in the batter, you can't just sprinkle it on top and expect it to taste like a cake. And that's where we've been with equity. We baked in inequity. We baked the cake where African people of African ancestry were not even considered a whole person, a whole human being. We were considered a fraction, 3/5 of a person. And now we've got this cake called Our Great Nation, and we're trying to figure out how to have it be a cake that's palatable to all of us. But we've got a fundamental missing. So there is a movement afoot, and our president is doing a lot of work to address racial equity and get it baked in. So the movement to mandate equity is about dealing with the systems and the structures that exist that by their very design had baked into them a fundamental missing, which is the belief in fairness and no hierarchy on the value of human life, that all lives, regardless of race, color, religion, sexual orientation, where you live, geography, would be fairly and equally valued. So mandate equity is calling our legislators to the forefront to ask them to use their power and legislative authority to get laws on the books and get things in place that will bake equity in to our society.
Thank you, Dr. Deborah. I appreciate you coming out from the background. We have only 1.5 minutes left. So I'm going to just ask each one of our panelists, give us one word that's going to take us out of this conversation today. Dr. Hacker.
Vaccinate.
Thank you.
Dr. Young.
I want to reiterate that I got both of my doses of the Pfizer vaccine earlier this year. I'm doing well. I'm healthy and I'm fine, doing well. And I recommend that all pregnant women, any woman contemplating pregnancy, and lactating women, all the Pfizer, Moderna, Johnson & Johnson are all safe and effective for this population of women. So I recommend it. It's obviously an informed decision. Use reliable resources, CDC, the health department, and go to your physician.
Thank you. Dr. EJ.
Primary care. That's 2 words. Dang.
Yep.
Vaccinate.
All right. Dr. Reynolds. I know it's hard. Give us a word. You're on mute, doctor.
Don't accept negative narratives. Don't fall for people of color. Don't want to get vaccinated. Find out for yourself and check the data before you accept the story.
Thank you, and thank you all for watching to our wonderful panel today. We appreciate you for joining us and sharing this information. We want to encourage our community health workers and social workers to complete the forms immediately after this session so that you can get those contact hours that are so needed. And we want to let you all know that we'll be back here on next Friday. Next Friday, we'll have our regular community webinar on coronavirus, and we need you to come out and just help us because you're helping us share information with our overall community. And we have to do this together. If it's going to change, it requires a community working together to make that happen. So I want to thank you for joining us today. Like us on Facebook, YouTube. Join us by signing into the info at healthyflint.org. And we will look forward to seeing you right back here next Friday at 12 noon.